I'm Dr. Camacho. We are going to talk about obstructive sleep apnea today. Here you can see normal airflow, and oxygen comes into the nose, goes into the airway, carbon dioxide is breathed out. And what happens during snoring is that you end up having obstruction of the airway. However, you can still have airflow. In this case, I'm showing the soft palate and the uvula being the site of obstruction. Once the tongue is involved, as you can see here, the air really doesn't want to move much at all because the more the lungs pull down on the upper airway, such as the tongue, it ends up sucking it back more. You can also have obstruction of the tongue, soft palate, and the uvula. Let's look at risk factors for snoring and obstructive sleep apnea. Here you see a gentleman who is morbidly obese. The problem when you're larger is that the airway will narrow because fat deposits on the tongue and the back of the throat. In this case, we can see that this gentleman has a very narrow airway when he's in the off season. So once he gains weight from powerlifting, and then if he's competing at his leaner weight, his airway is bigger because there's less fat, less fluid, less bulk. Some people have a very narrow upper jaw and lower jaw. You can see dental crowding, which I'm pointing out here in this picture. Syndromic children, such as Down syndrome, can have obstructive sleep apnea for multiple reasons, including neuromuscular dysfunction, meaning the muscles don't respond as well to the nerves telling the body to breathe at night. Also, a lot of these children are obese. This illustration shows Beckwith-Wiedemann syndrome, and that's a health condition in which the tongue and other structures are larger than normal, and this can also cause obstruction of the upper airway. This gentleman has either acromegaly or gigantism, and it all depends when the growth hormone is released. If it is before the bones are fused, we call it gigantism. If it's after, then it's acromegaly. And typically, these patients have obstructive sleep apnea because the tongue, the throat, neck, all the soft tissues get bigger, and that narrows the airway. And after the growth hormone was released several years, you can see that the patient is now larger, has more muscle mass, but at the same time, you can see the change in the facial features in the jaw, the chin. The bones are elongated. They also get bigger fingers, feet, so often the shoes don't fit anymore. Genetics, you definitely have a component of genetics. So in this example, if the dad has obstructive sleep apnea, the child is also more likely to develop obstructive sleep apnea, even if the mother doesn't have a history of it. So it tends to have a genetic component. As we age, just like the tissues in the face become more relaxed, the skin becomes more lax. Inside the throat, the same thing happens. A deviated nasal septum, so if this patient had trauma, can't breathe well through his nose, you can see the outside is crooked, but also the inside, the septum on the inside is crooked, and the tissues become larger on the side opposite to the deviation, and the side of the deviation is narrower. So what happens is as the air goes into the airway, as you're breathing, the velocity is faster, and it makes you stop breathing more easily because it collapses the walls in the throat. Here we can see a man who's about to have surgery. What happens is the anesthesiologist help the patient fall asleep with the medications. They put in a breathing tube, and then the surgeon will lift the hood, so to speak, to do a rhinoplasty. And in this case, we can see that grafts were placed. The blue ones are spreader grafts on the side. There's multiple names depending on where they're placed. And in the front is what we call a columellar graft. The whole point is we're trying to keep the nose more open. Here you can see a girl who has large adenoids, chronic mouth breathing. So shrinking the adenoids, improving the nasal airflow should get rid of the sleep apnea if the child is 2 or 3 years old and under, or if the child has small tonsils and huge adenoids, that might also help. Here we see a younger child with Pierre Robin sequence. Part of this problem is that the lower jaw is small, so it tends to stick back farther than normal, which means that the tongue is going to protrude out. Sometimes they also have a cleft palate. But the procedure of choice would probably be to distract their mandible or to move the lower jaw forward to help pull the airway more open. Now we'll talk about treatments. The main treatment for adults is CPAP, continuous positive airway pressure therapy. Now it's called APAP and because the machines are auto-titrating. And the bottom line here is air is coming into the nose or the mouth, or both, depending on the mask. It pushes the air into the airway and holds it open like a stent. The best analogy I can think of is if you have a flat tire, you know how the top and the bottom part of the tire are now touching. Once you patch the hole, reinflate it, it doesn't matter where you push on the tire, it's going to stay open. Similar here, a CPAP or APAP is going to help you keep your airway open. This is a classic CPAP machine. Basically, you have a compressor, which here is shown in black. Right next to it, there's a humidifier. And then you have a hose that goes to the mask that then blows air into the face. Here we see a woman who's wearing an oral appliance, which I'm showing in green. And basically, it's a device you put in your upper jaw, lower jaw, and it moves your lower jaw forward to keep your airway open. Similarly, you can see a tongue retaining device is going to pull the tongue forward, opening the airway space. So very similar idea to an oral appliance, except that it sucks onto the tongue. And all of these you can buy online for an inexpensive price. Generally speaking, if you're going to have an oral appliance, I recommend you see a dental sleep specialist. Tongue exercises, you can see myofunctional therapy is another name for these. You put your tongue to the right, put it to the left, up, down, 10 minutes, twice a day. After 3 months, believe it or not, studies have shown a 50% improvement in sleep apnea for adults and about 2/3 improvement in children. I would not say this is a primary therapy, but it can be used to help as an adjunct therapy. Here we see a chin strap. Chin straps go around the head, and the main goal is to keep the mouth closed during sleep. This may be helpful for someone who opens their mouth a lot. However, studies have shown just one person, an elderly man, who had severe sleep apnea, and once his mouth was closed with a chin strap, he was cured of sleep apnea. Although they do sell these online, I generally wouldn't recommend them for sleep apnea since that was the only patient that I can find in the literature who was actually helped by this. In some patients who have CPAP and they can't keep their mouth shut at night, this is a good way to help them with that. So it's called a chin strap. Tonsils. A are small tonsils, B are medium, C are large, and D are extra large. Usually once the tonsils are large or extra large, we can do a tonsillectomy in children or adults to help with sleep apnea. Notice, however, that the tonsils do have a lot of blood supply to them. So generally speaking, we don't want to just take out the tonsils. We want to make sure they have sleep apnea or another health condition in which tonsillectomy is indicated. Here you can see the uvula. This is like a punching bag that hangs down in the back of the throat. The soft palate vibrates, the uvula hits the spine, it gets longer, wider. Once it's more than 1.2 centimeters, there's a higher chance that the patient has sleep apnea. These are different procedures that we have done in the past to help sleep apnea. A is called a uvulopalatal flap, and we fold the uvula up. B is tonsillectomy. And maybe the uvula was trimmed in that case if it was longer. C is uvulopalatal-pharyngoplasty. D is the classic uvulopalatal-pharyngoplasty in which we even cut the center portion. And almost all of those patients develop globus sensation where they feel like something stuck in their throat. And I don't recommend that surgery anymore. Here we look at the tongue size. A is normal, B is moderately enlarged, C is large, and D is very large. And we base it on whether you see the soft palate and the uvula. And the closer you are to D, so the bigger your tongue, the more likely you are to have a poor response to tonsillectomy or other procedures just because the tongue is so big. Here's a classic sign outside the tongue. It's called tongue scalloping. And that's when you see the indentation from the teeth. And that just means that the tongue is too big for the size of the lower jaw. So when you sleep, it's more likely to fall back. Frenulum, this is highly debatable. In children who have trouble with breastfeeding and their tongue is tethered down, it's a clear indication to potentially do a frenulectomy for tongue tie. But once a child is older, it depends on how long this is and whether it's affecting their speech or other problems as to whether or not we're going to cut it. We usually will perform the frenulectomy in the clinic if it's a newborn. If they're a few months old or older, then we often go to the operating room. Sometimes we will take an adult or child to the operating room to shrink the size of the tongue. In this case, the tongue is cut in the midline and it's shrunken from the inside. That's called submucosal intralingual excision, SMILE procedure. Often we'll shrink the back part of the tongue, which is called the base of the tongue, in a lingual tonsillectomy. Usually to help us decide, we're going to scope patients in the clinic. And we're also looking for what's called laryngomalacia. And as you see here, on the right side of the screen, the tissue is coming in and it's kind of blocking the airway. In some children and adults, about 10% of them, we call it sleep exclusive laryngomalacia, to where they're not blocking or they don't have stridor while they're awake, but then when they sleep, the tissue does relax. So in that case, we would consider supraglottoplasty, which is a procedure to open the airway at this level. For adults and children, we're usually going to scope them in the clinic and sometimes in the operating room. If we do it in the operating room, we're going to wait till the patient's asleep, and then we look with the scope, and we're going to grade the different areas to include the palate, uvula, tongue, tonsil area, epiglottis, to see what is blocking. And depending on what is blocking, we may or may not do a procedure to help open that area. Here we see the classic view from above when we're scoping. In this case, you can see the entire airway, but sometimes you can block the entire airway with the back of the tongue. And in that case, you might consider a tongue surgery. A drug-induced sleep endoscopy is when we give medications to see what is blocking while the patient is sleeping, because we don't go to your house and watch you at home. We do it in the operating room. It takes about 15 to 30 minutes. This is the classic uvulopalatopharyngoplasty, not commonly performed anymore. We do the surgery in which we take out the tonsils, suture the walls together on the sides, but the uvula, instead of cutting it off like it almost is here, we usually will leave about 1 centimeter. Here's a more aggressive version in which the muscles are cut and pulled off to the side. It does open the airway more. However, it is not as commonly performed. Jaw surgery. This is a maxillomandibular advancement, and the upper jaw, lower jaw are cut. They're pulled forward, and then plates and screws are placed. Sometimes we'll move the chin forward as well. And this is called a genioplasty, where we make a little window, slide the bone, and then put a screw. And you can see here, what happens when you do that is the muscle comes through the bone and it holds it forward. Here we have a tracheostomy, and this is the ultimate surgery that we used to do regularly for sleep apnea up until CPAP. Basically, you make a hole in the neck, put the tube in, and it helps oxygen and carbon dioxide to come in and out, keeping the airway open. This video is just for educational purposes, not meant to provide specific medical advice. please see a healthcare professional. And no support was given for this video. The views are mine only. They don't represent the Department of Defense, military, Army. Thank you for watching.